Right, you're watching TVC Breakfast. On this segment, we're looking at the challenges in health sector, but with high hopes and expectation, as very soon we expect the ministers to resume their offices after the screening process, because the president has submitted the list of new ministers to the Senate, and we're trying to set agenda here. What kind of health sector are we looking at, and who should mount it or who should man it? And what are the challenges? What areas of priority should the person, start from? So we have Dr. Rasheed Abati, the Chief Medical Director, Heritage Men's Clinic here, and he has been helping us to make sense of some of these issues, making comparison here and there. Well, Kemi, you were going to...
Yes, I wanted to ask Dr. Abbas about our current framework of health insurance policy, because that is something that many people have called a revolution, but here in the Nigerian experience, not many people feel they've been well served on the part of the companies concerned, on the part of government, on the part of the hospitals themselves. So looking at, where you are from, the American experience,
Yes.
And where the potential that Nigeria is yet to tap from in this issue of health insurance. What do you think?
No, that's another angle to look at it. So based in Washington, D.C., it's an hybrid where employment-based insurances. So the goal is you get a lot of people employed and the private companies can provide insurances. And then you have an hybrid of, if you're in a low socioeconomic level, the government comes in with what is called Medicaid. There is Medicaid in U.S. and Medicare. Medicare you get as a result of your length of years of working, whether private or as a civil servant. Medicaid, as the word implies, the government is caring for you, whether for lack of whatever reasons you find yourself in that trench. Disability, medical condition. For example, dialysis, all dialysis patients in the U.S. are paid for by the government. Wow. Whether you can afford it or not is under Medicaid. So now let's bring that to Lagos, or let's bring it to Nigeria. We need an hybrid system. Again, I feel strongly, it's my personal opinion, I don't think the government alone can fund it. We cannot do the NHS of England, we cannot do the NHS of Canada. There's training. So let's do an hybrid. I advocate for a mixture of those, where government comes in, whether because of disability or because of a particular pressing issue. In this case, we're spending a lot of money on specialized care. 2 billion and up, going up for foreign money. It's not coming back to us. A lot of times our people...
It's gone.
It's gone, it's gone. A lot of times our patients come back in body bags. So it's about time we face reality. If we can have a blend, an hybrid. Government will still be taking care of little kids. In the US, you have a baby, it's government care. Government even provide you some milk, whether you can afford it or not. It's basic, it's been passed into the law. That's where we need the policy. And then when you are elderly, 65 and above or whatever the age the government determines, we know you are no longer productive, but you've been productive once before. So government needs to be able to bring you back in. And then we want the private sector to put in. So, the likes of the big companies, they hire you, then you have some form of insurance.
Talking about this private sector, because the way businessmen think is the issue of meeting a need somewhere where something is lacking. But we have been talking about inadequacies in the health sector all the while in Nigeria. Isn't that a good enough, reason why a private sector will say, okay, let me move into the health sector and invest there? Because, one way or the other, even if you're seeing it from the business perspective, it's still lucrative.
Absolutely. And let me tell you, from my own angle as a private medical person, the issue is financing. Okay. My clinic has been in existence for 4 years. We're thriving. We need to expand. The banks are ready. They've given us term sheets, but they're asking for 27% interest rate. It's not sustainable. So if you're expecting a foreign private investor to come and take a chance, it's difficult. I have a skin in the game. I'm a Nigerian. I want to be home. And there are other Nigerian doctors abroad that wants to be home. But we need that soft landing. We're not asking for 0%. No, the government can cap the interest rate, 9, 10. It's doable. 27%, 20% is not doable. Because we're not manufacturing, we're taking care. There's a part of you that has to be compassionate. There will be free care that will be done. And when government steps in, then government can have a say. Because that happens also in the US, where you're getting government taxes, the government can tell you how much you can charge the underserved. The government can tell you where to expand. Let the free market play.
And, amidst all of this, I also want you to, kind of clarify or, proffer solutions to the issue of brain drain. You've spoken about it. Nigerians, there are Nigerian professionals here who are eyeing the abroad, and there are people there who want to return home, but, economic factors, necessitate that they travel for greener pastures. And so many solutions have been, made here. Some say, and that costs a major uproar. Let all the professionals within their first 5 years of graduation stay back home compulsorily, and that costs, so much, backlash. And there's been so much here and there. But, from your, standpoint, what do you think is the way to go? Because we will always have people traveling, for economic reasons.
And personally, from someone that grew up here and went abroad for over 3 decades now, I think the grass is always greener on the other side until you actually know. What I'm employing our government to do is, let's try to make the grass a little greener on this side. Our doctors, a lot of them who were, jackpotting, getting out, is because they were overwhelmed. They actually had no hope in the system here. It's like sending them to the battlefront and having their hands tied. So it's not possible. And there is no way any government in the world can stop its people from migrating. So what we need to do is, let's look, what is it they're going there for? We're not going to become an American society overnight, but yes, there might be mixture of opportunities or solutions. The issue of trying to put a timeline once you graduate because the government has funded your education, that makes sense. We're not saying it has to be permanent, but if you make the condition a lot better here, you'll be surprised. A lot of the Nigerian doctors that were migrating, they are not able to practice over there. So
that's the downside. That's a reality.
That's the reality. They are not able to practice over there.
Why?
I'm involved because they have to take a lot of strenuous examinations. They have a 10-year window to take a 4-step exam. You'll be surprised. Over 50% of them do not pass the exam. So we need to look back inwards and say, why are these people living? Why? Because a lot of them have to uproot their family, and some of them will give you the excuse they're doing it for their kids' sake. So if we look at that, we might need to piece it down and break it down into phases and see where are they moving. The financial one is there because they know they get more money over there because the US needs doctors. The UK need doctors. The Canadians need doctors. So why are we training them for free?
You talk about the 4-level test for anyone who is coming. We assume that, in the medical profession, there are benchmarks where you have to meet before you can practice and so on. Now, what is that extra thing, either in the US or any of those, climes, that makes someone who is qualified and certified from a Nigerian environment, that doesn't make him meet up? What's that extra thing?
So the truth of the matter is our curriculum here has not changed in decades. And these are countries where they're on rapid speed in terms of curriculum and meeting their population demands. In the US, you have to take the United States Medical Exam Board, which is USMLE, step 1, 2, and 3, in order to show that you're actually qualified. Not only that, the last set of exams, you need to be very familiar with the laws, and you need to be familiar with what are the patient requirements there. What the American patient needs might be slightly different from what the Nigerian patient needs. And so these are exams that are tough. And our curriculum, like I said, I went through 8 years of medical training with the best of the best. We were talking Nobel winners. Clinical exposure is there. We're lacking here. When I was in medical school, my first 2 years with a dead body, I had only one person to share the dead body with me. You want to take a guess how many Nigerian students share dead bodies? Over 20. It's not possible. And that is where the private sector needs to come in also. A lot of the medical schools in America, they're not government-owned. These are private. And so they invest. Of course, it comes at a price. And what the government did for me as an American citizen when I got the admission was to guarantee my student loan. So if the government did that, it comes at a price. So I cannot just jackpot, even if another country is offering me more money. Because I've been bailed out by a government that felt like, okay, we need future doctors, so let's invest. So if we do that, we're investing and we're paying down the road.
Wow. And attached to all of this, again, is welfare. Still on the subject of strike, of industrial actions, there's still a large crop of Nigerians who feel the doctors are asking for too much. But, we've listened to them over and over, speak about how specialized their industry is, how that, okay, even at this time of fuel subsidy removal, while, you know, people in other professions are finding a leeway around it, it's not like that for them, because they still have to work, you know, overtime and all that. And again, there's the issue of empathy and professionalism of doctors in this climb. But from your own standpoint, again, are we being fair to the doctors, or are they asking for too much in this part of the world?
Well, as a physician, and I'm not trying to be biased, it's just that we put our doctors in a tough situation. So let's put aside their requirements for one. Let's look at the support system. Are we giving them even enough support? How many nurses do we have for each doctor that is practicing? If you and I walk over to Ikeja, Lasucom now, you see it's a glaring shortage. And what does this translate to? Poor patient care. Because when you expect one consultant to see over 100 people a day, and he or she has only one nurse to help, that's a recipe for failure. So yes, the doctors may be striking now, which if you look at it ethically, it's even against our profession, because they're not going to be able to walk away from a patient that needs them. But the doctors are also, they are micro component of another family. They need something to provide for their family. They've invested all these years in medical education. So all we're asking for, from my angle, it's a little bit. Meet them halfway. And if you meet them halfway, talking about the type of caliber of a minister, you need someone that has the government backing and know what's at stake. Because it's not just about what the doctors are asking for. It's not about them just jackpotting. We're talking about patients' life lost. We're talking about quality life lost. And so we can fix this.
Mm. All right, let's talk a little bit before we go about primary health care. What we understand is that a lot of the things people take to teaching hospital are some of the things that could have been handled at the level of primary health care, or left to degenerate, you know, that could have been handled at the level of primary health care, and then nothing happened, and then, you know, there are layers, primary, secondary, before tertiary. A lot of our people may not necessarily understand that, you know, there are ailments that fall in different categories and all of that. But the government, from the report we got, that they'll be investing in at least the primary health care per ward in every local government and all of that. It's really ambitious. But we've had it before. It's not like it's not anything new. But how would that contribute to the kind of health care that everybody is looking forward to?
That's a good point. So I believe strongly that we're cutting and pasting. But let's go back to the genesis of all this. So for example, in the US, we have the situation of a primary health care. We have emergency care. The goal of a provider, a medical provider, is to reduce the number of his or her patients that end up in emergency. Anywhere in the world, the more people that end up in emergency, the more will likely die. So your goal as a provider is reduce the number that goes from primary care to emergency. There is a gap missing there. That is the urgent care. We don't have it here. Where, you know, your primary care is, I don't have to have headache. I have to have a doctor that I go to, maybe annually for normal checkup before something bad comes out. But in the interim, maybe on a weekend, if I develop an headache, do I go to the emergency room? No, if I do that, I'm going to overwhelm that system. I need to go to an urgent care. So our government is missing. The idea of primary care is fantastic, but let's do it the right way. There has to be primary care, urgent care, and emergency. When you go through that three-legged stool, you're going to protect your system. And all we need is good institution.
All right, good to know. And I wonder, your name can still be on the list.
With all he said.
Dr. Rasheed Abati, Chief Medical Director, Heritage Men's Clinic, thank you so much for talking to us, and thanks for the insight and all of those things. I hope that the government has a very robust plan, you know, that is in tune with this as a way of turning things around. Thank you very much.
Thank you so much for having me.
Great.